Good afternoon, everyone. Welcome to this nutritional webinar. Thank you for being here with us today to share and update information on pediatric nutrition. Before we start, I have some logistic information from this event. We are broadcasting this webinar through two platforms. We have the Zoom with the ID that you can see on the screen, and also via YouTube using the words Travel Solutions. Both have question and answer sections that you can be free to upload any question that you think that is relevant or you want to know about this topic. Well, today our topic is intestinal microbiota and probiotics in pediatric health. For that topic, we have the speaker of the night is Dr. Saavedra. Dr. Saavedra is a pediatrician and gastroenterologist, which is also an investigator, educator, and a medical and scientific business executive. He created and developed the Child Nutrition Center at Johns Hopkins, which he directed for 10 years. Dr. Saavedra carried out groundbreaking work in the area of probiotics in pediatrics and have an extensive record of publication in nutrition and in the area of intestinal microbiota, gastrointestinal disorders, and preventive nutritional strategies. He spearheaded a number of collaborative initiatives on education and dissemination of nutrition knowledge focused on early childhood nutrition education with pediatric and nutrition societies and organizations globally. That include NASGAN, ESPAGAN, American Academy of Pediatrics, the National Academies of Science in Washington, D.C., and the UNESCO. He recently published a book entirely dedicated to the impact of early life nutrition on lifelong health consequences, focusing on nutrition in the first 1,000 days and society's biggest opportunity for progress. Actually, Dr. Saavedra is Associated Professor of Pediatrics at Johns Hopkins University School of Medicine. Let's welcome Dr. Saavedra. Doctors, the floor is yours.
Thank you very much, Hegla. Thank you very much, Hegla. Hopefully you can hear me well. It's truly an opportunity that is difficult to have these days, but I hope we can make the most of it to meet, albeit virtually, and learn together and exchange ideas with regards to some of these important topics that are relevant to taking care of infants and children today. This topic of the intestinal microbiota as it relates to infants and how they can be part of the foundation for long-term health is something that really is exploding in the literature, not only in the scientific literature, but certainly in the lay literature. And how early life shapes the infant gut microbiome is a critical component of the many things that we can and we may be able to modify in ways that help support the health of children. The microbiota is this collection of microorganisms that we have in the gut, and they exist in very large numbers and very large groups of genus and species, all under specific phyla. And the phylum of bifidobacteria of bacteria in the gut vary so much that it ends up being one of the most densely populated ecosystems on Earth, one gastrointestinal system, one GI tract. We have the average person has more than 10 times the number of bacteria in the gut, the number of cells in that body, in that host, with a very large amount of genes that now have been encoded and 4 particular dominant phyla. Remember, bacteria, we measure them and we characterize them in this large group of phylum, which have different classes and orders of bacteria, which have different genus and different species of bacteria. These are the 4 big phyla that you will be increasingly hearing in the literature as we now have mechanisms to characterize the genes of these bacteria and really get a good full profile of what the gut microbiota looks like in infants and children, and certainly in adults. Under the phyla of firmicutes, that includes lactobacilli, as well as things like Staphylococcus and Clostridium. Bacteroides is another large group. Proteobacteria is where most of the pathogens are. Enterobacteria, Salmonella, Shigella, Pseudomonas are all proteobacteria. And there's one phylum, which is called the Actinobacteria, under which we have the genus of Bifidobacteria, which we'll be talking a little bit more about. Now, most of these bacteria that are in the gut are in a very close association with the lining or the epithelium of the gut and the gut-associated lymphoid tissue. And it is important to understand that the GALT is a collection of immune active cells that conforms about 75% of all immunologically active tissue and cells in the body. And they are strategically situated in the gut in proximity with this very large number of microbes. There's many functions that the microbiota serves. One of them, of course, has to do with balancing each other within the gut. But the GALT structures and these cells, which are situated just across the epithelium, are in constant communication with the immunologically active cells of the intestine. Now, there are many mechanisms by which they exert a protective function. Bacteria in the gut compete with pathogens that are in the lumen. They enhance the mucosal barrier because they stimulate the epithelium to secrete mucus and mucin and strengthen their tight junctions between cells. Microbiota induce the immune system to secrete antibodies, and specifically immunoglobulin A. And they also train and modulate the gut immune response by stimulating both Th1 and Th2 cell types so that you can still protect yourself, but minimize the chances that you have an immunologically overreaction and lead to inflammatory gut conditions, for example. Now, the gut-brain axis is another very important component of what we now understand is a result of the composition of microbiota also in the gut. We've known, but we are now better understanding the multiple mechanisms of communication between the gut and the brain, each one of which has different types of functions that, on the one hand, are important at an organ level, i.e. psychosocial functions, and our brain and central nervous system depend on life balance and environmental and social inputs. On the other hand, of course, GI physiology depends on the function of the gut, its motility, its sensation, and we understand now its microbiota. Now, there's a connection, there's multiple connections between the gut and the brain. Certainly the spinal cord, the vagus nerve, blood circulation between both organs, as well as endocrine connections, including the hypophysis, pituitary, and adrenal axes. These connections also connect then the functions of the brain and the gut via many of these communication mechanisms, and connect the brain central nervous system and the gut enteral nervous system. So the constant communication which happens between these can also lead to negative imbalances and changes that can lead to disorders. Certainly environmental and social stress on the one hand, and as we said before, changes in gut sensitivity, immune function, inflammation, and altered microbiota. Those alterations and this constant communication lead today to what we call functional gastrointestinal diseases. And there, infant colic, functional constipation, regurgitation are a consequence of this interaction between the gut and the brain. In fact, about a little more than 3 years ago, the Rome IV consensus redefined functional gastrointestinal disorders as those that are disorders of gut-brain interaction. And those GI symptoms that are part of these disorders in many ways are a combination of changes in motility, in altered microbiota, in hypersensitivity of the gut, and a number of other components which lead to functional disorders that that of course lead to signs and symptoms in an infant. So to summarize just the global effects of microbiota as it relates to GI function. First, of course, are the digestive functions that these are the things we knew about 100 years ago. Yes, many of these bacteria produce vitamins, they ferment carbohydrates, which is a very important function, lowers pH of the gut, and may actually metabolize carcinogens and other bacteria. But today, we know that immune development, protection and modulation, as well as enhancement of gut barrier function, is a major component of gut microbiota. And now we understand that they even have, because of this gut-brain axis, a function in the neurologic development and activity of an infant. And these ultimately explain most of the mechanisms on the right that we increasingly understand lead to either maintenance of health as well as potential diseases. So how does the microbiota develop? Of course, first for 9 months, the child is in the amniotic fluid where it's not completely sterile. We know now there are a few very tiny amounts of bacteria and specific species that may play a role in the intrauterine environment, and we're just figuring those out. However, when a baby is born, their meconium has hardly any bacteria. It's not completely sterile, but we go from a few hundred or thousands of bacteria to trillions of bacteria in just the first few hours of life. Especially in the first 72 hours, there's an explosion of bacteria that happen in the gastrointestinal tract of an infant. So the infant goes from having very little bacteria to a full ecosystem of microbes in the gut in very few days. And as time passes, this microbiota begins stabilizing so that you develop, and each child develops their own profile of the ecosystem in their gut. And for reasons that are not completely clear to us, there is an interesting symbiosis between the genus human and bifidobacteria. This genus of bacteria that is the predominant species, especially in babies that are born vaginally and who breastfeed. Healthy, vaginally born breastfeeding babies have more bifidobacteria than any other genus in their GI tract. And we do know that breastfeeding, in many ways, protects infants, not only from infectious diseases, anywhere from otitis to GI and respiratory illness, immunologic diseases. We know that breastfeeding modulates the intestinal immunologic system to decrease the risk of allergies and asthma and type 1 diabetes and IBD, and a few other metabolic diseases like obesity, for example. Now we find links between the early the early provision of breastfeeding, breast milk, and the development of diabetes. So this link between microbiota and disease and breastfeeding is beginning to be elucidated more. We know breastfed babies have more bifidobacteria, especially when they're born vaginally, than non-breastfed babies. And the red part of those circles are actinobacteria, mostly bifidobacteria. These bifidobacteria tend to be the predominant species across the board, but especially in infants who are breastfed. On the other hand, we also know not only breastfeeding has an effect on disease, but C-section does. And we know the babies born by C-section today have increased risk of developing type 1 diabetes, developing asthma, atopic dermatitis, celiac disease, and very interestingly, even food allergies. When we look at the risk of food allergies in babies who are born vaginally with no maternal history, they have the lowest risk of developing food-related allergies. If that population has children, or those children who are born vaginally, their parents, and specifically mom, has a history of allergy, they have a significantly higher risk, 2 to 3 times as high. However, if children have a maternal history of allergy and they're born by C-section, their risk increases manyfold. And we really do not talk about the chronic consequences of cesarean birth as it relates, for example, to allergic disease, which increasingly becomes clear is modulated by the type of bacteria that babies have when they're born vaginally versus when they're born by C-section. So there is this link between microbiota, immune modulation and development, and disease. Now, in addition, there's been an evolution in the environment that has changed things. We understand that this microbiota is highly dependent on the environment, right? If a baby breastfeeds, it's born vaginally, and what the environment looks like. If they're born in the hospital versus born at home, if they're born in a rural area versus born in the city. These environmental changes have also changed our microbial experience. And when we look at industrialized modern society, in the increased number of C-section births, the lack of breastfeeding and use of formulas with no bacteria, the sanitation of food and water. We need to remember it's only been 100 years, about 120 years since Louis Pasteur that we began pasteurizing and sanitizing our food because of our understanding of pathogens. So for a very good reason, we did that, but we also decreased drastically the amount of bacteria that on a daily basis a human consumed. We moved from the farms, where there's a large exposure to microbes of animals, to the city. And of course, we started using antibiotics. And we cannot underestimate the serious effect that antibiotics have in wreaking havoc on the microbiota of any individual, especially when you take broad spectrum antibiotics. These completely change these microbes. So modern life has led to a very different microbial exposure than what we were evolutionarily built to have. And this has altered the intestinal microbiota to what we today called dysbiosis, or an imbalanced set of microbes, which in turn lead to these inadequate immune responses and inadequate gut-brain axis function. And the consequence is lower protection, particularly to viral infections, an overexpression of the immune system, allergy, asthma, inflammatory bowel disease, and as we said before, also potentially to increase in functional disorders like colic and constipation and regurgitation. So if we look at these primary sources of bacteria for babies at birth, as we said before, the mother, the vaginal canal, the circulation during delivery, etc., and breastfeeding, all promote a balanced microbiota with a predominance of bifidobacteria that minimizes the chances of disease. On the other hand, babies born by C-section who are formula fed, who receive antibiotics, or who have environments that provide different types of microbes will promote a dysbiosis and an alteration of the microbial flora. And here, conceptually, is the idea that we can help rebalance part of this dysbiosis by the provision of oral bacteria, what we today call probiotics. And just to anchor the definition here, the International Society for Pre and Probiotics today, and this is probably the most widely used definition of these microorganisms, states of them as live organisms, which when administered in adequate amounts confer a benefit to the host. If a bacteria does not have a benefit for a particular population, we would not and should not consider it a probiotic, even if it doesn't do anything. Now, we don't have time to go over the whole discussion of what are the potential effects of supplementing the diet with probiotics, with live bacteria. And again, different genus, different species of bacteria have shown in different levels and in different levels of activity, similar effects of what we see with the microbiota. They can improve gut permeability, increase mucus productions, secretion of IgA, improve natural killer cell activity in circulation, improve macrophage and phagocytic activity, and modulate towards antigen tolerance. And when it comes to the clinical correlates of those effects that have been broadly seen with different species of bacteria in different levels and different populations, we can certainly modulate the intestinal microbiota. Giving oral bacteria changes in varying amounts the profile of bacteria in a baby. It reduces, can have an effect in acute diarrhea, particularly risk reduction of viral diarrhea, of respiratory infections. We'll talk briefly about how certain species can decrease crying time in babies with colic, can decrease, and we don't have time to discuss this, can decrease allergic reactions and atopic dermatitis. And in premature babies, there's a lot of literature now with regards to the use of probiotics to prevent necrotizing enterocolitis. Now, we don't have time to review all the different species and genus that have been used, but there's two specific genus of bacteria that it is important to mention because the vast majority of probiotic bacteria fall into the genus Bifidobacteria or the genus Lactobacilli. And within the genus Bifidobacteria, there's many species, Longum, Animalis, etc., that have different activities and different rates of survival and have different effects. On the genus Lactobacillus, we again have a number of species that have different effects that have been shown with different populations. Now, I'll focus on two specific ones because these are the ones that have the biggest safety record for infants. And just to begin and probably give the earliest example of use of microbes in infants is the use of Bifidobacterium animalis subspecies lactis, or B. lactis, as we call it, in the specific strain BB12. These in particular have been shown to increase bifidobacteria and balance the microbiota, increase secretory IgA, increase gut barrier function, and they have also been used in clinical or identifying clinical outcomes such as reducing risk of acute diarrhea, allergy, and NEC. These have been the observed clinical benefits with B. lactis. And very importantly, B. lactis was the first bacteria to achieve GRAS status, or what we call generally regarded as safe status, from the US FDA for use in infants from birth. We go back to the early 90s when B. lactis was used for the first time to show, and the results were replicated in Europe, showing that the risk of rotaviral diarrhea and the shedding of rotavirus can be decreased with the use of supplementation of B. lactis in the diet of infants. And these were the earliest studies to demonstrate actually an effect of probiotics in general and B. lactis specifically. Just moving forward to some of the latest findings that relate to B. lactis has to do with IgA secretion. Now we know breast milk provides an infant secretory IgA, which gives them passive protection. Infants who receive secretory IgA via breast milk have significantly higher levels of IgA than infants who receive no human milk. And this passive protection is critical in terms of decreasing the chances of infants getting infections, particularly viral infections and viral diarrhea. Now, when a child is not breastfed, then they do not get secretory IgA. And in the green line, you see the secretory IgA in blood of an infant takes a much longer time to develop. So, and then maternal IgA in circulation, of course, the dark blue line goes back very quickly, and it takes time for the infant and total IgA to rise up again in a child, especially in the first year of life. So we have this protection gap when a child is not receiving passive protection via IgA in human milk. So one of the aspects, the functional aspects that has been looked at as it relates to the presence of secretory IgA in the gut of babies for protection has been looking at the use of bifidobacteria, B. lactis specifically in babies born by C-section or vaginally, where you can supplement oral bifidobacteria in their feeding and increase the amount of bifidobacteria levels in their gut, in the stool. And the blue bars, which are children supplemented with B. lactis versus children who are not, you see are higher in the indicating a higher density of bifidobacteria in their intestine. And interestingly, we see that the effect is higher in infants born by C-section, which of course are those that are particularly prone to having dysbiosis compared to vaginally born babies. And when we look at the changes in secretory IgA in 6 weeks or at 12 weeks on the right, again, the provision of B. lactis can increase the secretory IgA in the stool of babies. Babies who do not receive probiotics actually decrease, because that's the normal change, that's the normal decrease that we see in babies over time. So there is there's a functional effect of B. lactis specifically on increasing secretory IgA, which correlates well with the protection that bifidobacteria can provide infants. And when we look at specific anti-IgA antibodies, and here specifically looking at anti-rotaviral IgA. So these are babies who receive rotavirus, oral rotavirus vaccine. Again, you'll see that children who receive B. lactis will have a better antibody response, secretory IgA response, to rotavirus vaccine in all the babies on the left, but particularly a much bigger difference in those babies born by C-section, which is expected, assuming that these babies are not having the normal microbial experience that vaginally born babies have. So there's a correlation, again, between the potential of an antibody protective mechanism and reducing their relative risk. And to finish, B. lactis, and again, this becomes very important when we're talking about infants, using oral bacteria in infants, using probiotics requires that we're truly certain about the potential effect, but most importantly about their safety. And B. lactis in particular has been used now for more than 25 years. A number of systematic reviews and clinical trials showing that babies grow adequately, don't have any adverse events. And we mentioned already, it is considered safe by regulatory agencies. And that's true in North America, and it is true in Europe today. When it comes to the genus Lactobacillus, and again, we could focus on a few lactobacilli, which we'll mention at the end, but one of them has stood out in recent recent literature, in particular, and that is Lactobacillus reuteri. Now, this particular strain, it has two numbers and depends on the culture collection and the time that they registered, also with small changes between these strains. Today, this strain has been shown also to have very specific benefits, but not on the protective side of probiotic effect, but on the functional gastrointestinal side of probiotic effects. And probably the best understood potential clinical benefit of L. reuteri relates to functional gastrointestinal disease, and in particular to infant colic and crying. There's good evidence that it improves GI motility and gastric emptying in infants. It regulates bowel movements, and it also seems to have a protective effect in terms of risk reduction of diarrhea and respiratory infections, and is the only other bacterium, it's the only lactobacillus today that has GRAS status for infants. You know, most of the supplements of probiotics right now that are commercialized, many are just supplements, many are supplements with good data, and many are supplements that are not appropriate or have not been studied, especially for safety or efficacy in infants. When it comes to these functional disorders that we mentioned earlier, of course, particularly in infants, environmental and social stress and family perception of stress and so on. They interact, of course, with the child's reaction to their GI physiology. And if there is dysbiosis, this leads to what we mentioned earlier, these functional disorders that are very common in infants and children. The three most common disorders that are considered functional in infants include functional regurgitation, and that is spit up in the absence of disease, with no organic disease and adequate growth. These are happy babies who are spitting up. Infant colic, again, otherwise healthy babies that have inconsolable periods of crying, and the same thing with functional constipation. These are by far the most common functional gastrointestinal conditions in infants. Now, for colic, and I think it is important that we can and should not consider any crying as colic. Babies normally cry, and the crying tends to peak, in the first 4 to 8 weeks of life. But generally speaking, infant colic, again, using the Rome criteria that we mentioned earlier, are infants who are less than 5 months, who have these prolonged episodes of crying, typically 3 to 4 hours for more than 3 days in 1 week. They cannot be resolved by the caregivers, which also leads to this vicious cycle of stress, and are otherwise healthy. There's no growth failure, no fever, no illness, no evidence of organic disease. And now there's I think a very solid amount of literature showing that babies who have colic have dysbiosis. When you compare populations of children with colic versus not, babies with colic have less lactobacilli, have more coliforms, they have less diversity of bacteria in that ecosystem. And interestingly, that seems to lead to an increase in gut inflammatory markers. And in this particular example at the bottom right is calprotectin, which is a marker of inflammation in the gut. So there seems to be this relationship between these symptoms of crying and colic and an abnormal gut ecosystem. When we give oral Lactobacillus reuteri as a probiotic, we can see on the left, it increases the amount of lactobacilli in the stools of babies in the gut lumen. And of course, controls, you do not see a change. And you also see a decrease of E. coli in the gut of children who receive L. reuteri versus children who do not. And we don't have time to go through all the studies that have been done, but these particular studies looking at the crying time in infants diagnosed of colic by Rome criteria, the provision of L. reuteri over a period of about a month shows that the crying time, which normally decreases in kids with colic, usually resolves by the 4th or 5th month at the most, is much more accelerated, and crying time is improved in infants getting L. reuteri as a probiotic compared to babies who are not. And most of these studies to date have actually been done in breastfed babies who develop colic roughly at the same rate that formula-fed babies, and where you can see these very significant decreases in crying time. When you look at it in a different way, the number of children reducing their crying time with supplementation of Lactobacillus reuteri versus placebo, already at 1 week, you start seeing differences in the crying time resolution and the number of infants who cry for less than 50% of the time, and that decrease in of 50% of the increase in 50% reduction of crying time increases all throughout the month of treatment in this particular study. There's been a number of studies, as I mentioned, most of them in breastfed babies too, looking at the benefit of Lactobacillus reuteri in these infants. Interestingly, also, as it does seem to have an effect on what may be upper GI motility, their supplementation of L-reuteri reduces the frequency of spit up, of functional regurgitation. So, and again, all these in particular are non-breastfed babies who have frequent spit up, and providing Lactobacillus reuteri decreases the number of episodes of spit up over a period of a month. Here, at least 2 of the clinical trials showing a reduction in these number of episodes of spit up, and there's been 3 randomized control studies showing this a similar reduction with the use of probiotics, and particularly L-reuteri. And finally, again, back to this motility issue, functional constipation is one of those other significant gastrointestinal disorders that we see in babies around this age. And at the top, you see in a randomized controlled trial, the evolution of the frequency of bowel movements. And the blue bar is children having a bowel movement at least 5 times a week. That frequency increases in children supplemented with Lactobacillus reuteri versus the placebo group at the bottom, where there is slight improvement over time, just with dietary measures that all kids get, but is significantly lower than infants who get supplemented with L-reuteri. So there does seem to be this overall effect on motility. And as I mentioned earlier, L-reuteri does seem to also have a very significant effect on the protective mechanisms of probiotics, and specifically here, duration, number of episodes and duration of diarrhea and respiratory tract infections. This particular study done in Mexico, showing that children getting L-reuteri will have less days of diarrhea, less length and follow-up for diarrhea, and less respiratory tract infections following about a month of supplementation with Lactobacillus reuteri compared to controls. And similarly, I think, again, safety is important, and L-reuteri does have these multiple effects that we mentioned in terms of diarrhea, respiratory infections, and days of hospitalization. Again, not to forget, there's a number of other bacteria, B. longan subspecies infantis, or B. infantis, L. rhamnosus GG, Lactobacillus paracasei, the specific strain ST11. With different levels of evidence also have been shown to have similar effects to the 2 bacteria that we mentioned that are those that have GRAS status. These have just initially begun, and particularly B. infantis, have begun studying in infants. One final important understanding that we need to have is the interpretation of studies in probiotics. First of all, I think it is important, and we will see different levels of effect in different studies with different bacteria, and even with the same bacteria. So it is important, first of all, that when we talk about studies in probiotics, we're talking about a specific genus, a specific species and strain, that there is a safety profile for those bacteria, that we know how much we need to give. We won't, and if we have time to discuss those, but typically all probiotics with a clinical effect have been provided at about 10 to the 8th colony forming units on a daily basis. So that's 8 zeros of bacteria as a dose. And how you give them. It is important also to understand how the probiotic is given in a liquid, in a powder, in an infant formula, and so on. It is also important that when we talk about probiotics, we understand who we're giving it to. And this is, of course, going to also result in different effects in different populations. And the benefit may not be the same, for example, between a C-section baby and a vaginally formed baby. We may actually see a bigger benefit, as we have mentioned with some probiotics. You may see a bigger benefit, all in the same direction, but bigger in C-section babies because they have a higher risk. The same thing with breastfed babies. We'll obviously see, depending on what the effect is, and particularly for the protective effect, a better effect of probiotics in babies who are not being breastfeeding, because those are the babies at risk. Obviously, what diet they're getting and how they're getting it, and is the population receiving antibiotics, and how many children received antibiotics. All these factors will modulate and change the outcomes in a particular clinical trial. So it is important that we pay attention to this, and that helps explain sometimes why we see different effects with different bacteria, which of course we haven't had time to go over all of this, that would be expected by some of these bacteria. And finally, and I think this is also very important, we can't talk about general use of probiotics and say, well, probiotics are safe or probiotics are good. That's equivalent to saying, are antibiotics safe or antibiotics good? No, we can't speak that way. We need to understand that when we talk about probiotics, we need to talk about a particular bacteria for a particular population for a particular benefit. We can't just, make a blanket statement that probiotics work or don't work for A, B, or C condition. It is a specific bacterium at a dose in that population that is important. And of course, safety as well as the efficacy that we talked about needs to be considered when we make, general representations and conclusions with regards to the use of a bacterium or particular probiotic in children. So in closing, I think it is important to understand that these changes that occur in very early life, in fact, set the course for very long-term effects in health in individuals and obviously for all society. Breastfeeding, and every time we understand this, we understand even more what and how it is that breastfeeding provides everything, all the benefits that it provides, ultimately remains this model that should inspire the way that we're feeding babies. And in particular, we understand more and more today how breastfeeding plays a major role in shaping the microbiome of infants and overall health. In conclusion, as we said, the microbiota is this complex system that plays a critical role in host immunity and in modulating gut-brain axis function. Maternal and environmental factors, and particularly mode of birth and breastfeeding and antibiotics, shape the intestinal microbiota and makes certain children more at risk of dysbiosis and the consequences. And this alteration, which of the profile of bacteria, which we call dysbiosis, is clearly associated with immune and functional related health conditions. And probiotics as a concept can improve these conditions associated with dysbiosis, including immune response and modulation, and the clinical correlates of particularly respiratory and gastrointestinal infections, and improved functional GI disorders such as colic or regurgitation and constipation. And there are specific effects with specific bacteria that have been demonstrated. And finally, these recommendations on probiotics require that we talk about specific species and strains, and each one have a well-determined profile of safety and efficacy for the use that we're giving. So I'll stop there, and hopefully we have some questions that we can answer and we can address for the group. Thank you very much.
Thank you, Dr. Saavedra, for such extraordinary presentation. And we have some questions indeed. Is one interesting question is related autism.
Autism.
A microbiota.
Okay. All right. So we're starting with a controversial topic already. But I think, well, and I've been saying this more recently. If you had asked this question, 10 years ago, I'd say, oh, come on, you're crazy. There's no there's no relation. We know today that there may be a relationship between neurologic development and gut microbiota. Okay. That does not mean by any stretch that we're even close to showing that significant neurologic conditions like autism, right, are related to microbiota, and even less be able to say that a bacteria, an oral bacteria, and probiotics could help it. On the other hand, I cannot say there's no relationship. We just do not have enough data today to say that there's a relationship. There's been a couple of studies just in the last 3-4 years, and I've been part of one of these studies done by the psychiatric group at Hopkins, looking at use of probiotics in schizophrenia. And indeed, there were less recurrence of hospitalization in patients receiving, in this case, a lactobacillus, and these are all adult patients, of course, we're not talking children. So the short answer is, there may be a relationship between some neurodevelopmental conditions and potentially autism with the microbiota. However, we have not characterized what that relationship is, and we don't have mechanisms to understand it yet. And of course, even so, less with the use of probiotics. So we couldn't really make a recommendation today.
Okay, another question is, how safe is the use of probiotics in a patient on treatment for sepsis?
Yes, so yeah, that's a very important question. I think that is a good question. And again, the same thing. We used to have a very significant and very high level of concern for, and it's hard to talk about sepsis alone, but any patient that is immunocompromised, whether with severe infection or immunocompromised for some other reasons. And of course, we always have the concern if we're giving live bacteria to a patient, and we're talking infants in this particular case, you always have the concern that there could be translocation of bacteria that go into the bloodstream, and you have sepsis from the probiotic. And here's why, again, I emphasize the importance of understanding the safety record of a bacterium. The truth is, and I think it is important also to understand that a child with sepsis, a child who's on chemotherapy, a child who's in the ICU for whatever reason, and they're all immunosuppressed, they already have, billions of E. coli in the gut, right? So giving an oral bacterium that doesn't cause infection is the least of the concerns more often. And we do know that there are high-risk populations that in fact benefit from that. And this was not the topic of this talk, but if you look at the highest possible risk population, which are premature infants who are in an ICU, they're not breastfed, they're repeatedly getting antibiotics, they're in an environment that just is full of pathogens. In fact, one of the strongest evidences for specific probiotic bacteria has been in premature babies, where you actually prevent NEC and decrease sepsis and infections. So this is why the safety record is so important, and this is why, from my point of view, I again stick to the fact that we need to look at bacteria that have a documented record of safety in infants, and we give a couple of those examples.
Another question is, which parameters we have to take into consideration to initiate a treatment with probiotics?
Yeah, so I think, and that's a very practical question, because again, we're giving probiotics for a particular reason. And I would separate those into two big categories of reasons. The first is health maintenance. We want to give probiotics because we want to maintain the health of a baby, meaning a preventive type of approach or a risk reduction type of approach. And for that point of view, both Lactobacillus and L. reuteri, as examples, have been shown to decrease the risk of respiratory infections and gastrointestinal infections in infants. And then you're giving it for a risk reduction approach, which means you want to give it as part of the daily care of that child or part of the daily feeding of that child. And that's how you give it. And that's a very good example of what we have of B. lactis. In particular, or any bifidobacteria, especially when a baby is not receiving human milk, is not getting mom's milk, and is on formula, or even starts on weaning foods, then we have this gap. And it becomes even more important to be able to modulate that bacteria. So there you're giving it for prevention. On the other hand, if you're giving it for the purposes of decreasing severe colic in a baby, especially a breastfed baby with severe colic, you give a supplement of Lactobacillus reuteri. Or if a baby is not receiving probiotics and has colic in general, there is this potential of decreasing colic with Lactobacillus reuteri. So there you're giving it for that particular reason. And you could arguably give it for the period, for the couple of months that the child is having colic. But I think more and more we're starting to understand that providing bacteria that are safe in part of the feeding of a baby is maybe trying to swing back to what babies should be getting in the first place, which is a lot of bacteria on a daily basis, as long as they don't get pathogens together with that bacteria. And that's the concept of providing oral bacteria on a daily basis. And that's what guides the length of treatment. If you give a child bifidobacteria from birth when they're not breastfed for some reason. And lastly, I'll just mention as a general concept, to me, from the practical point of view, a baby who is born by C-section, who is not breastfed, who's on recurrent treatments of antibiotics for whatever reason, that's the high-risk populations that you can and would think of providing a safe probiotic on a regular basis.
Another question is yogurt a good probiotic?
Which? I'm sorry, I didn't.
Yogurt.
Yogurt. Okay. So yogurt is not a probiotic. Yogurt is a fermented milk with bacteria. And a fermented milk with live bacteria just means that that's what it is. If the bacteria in the yogurt are a species and a strain that has been shown to have a benefit, then yes, it is a probiotic. Unfortunately, the regulation for dairy products and adult, and regular food, and the regulation for supplements, is unfortunately not as strong as the regulation that we have for things like infant formula or infant cereals and so on, where we really, if we say, and if companies say this is what they should have, this is what they have. Unfortunately, the regulation for supplements has led to this explosion of products, many of which unfortunately don't contain, sometimes not even live bacteria, sometimes not in the amounts that they have, and sometimes not with the species and strain that they have. So, and there, unfortunately, we do have to trust the manufacturer in many ways. So yogurt is an excellent food. It's a great way to introduce dairy in the diets of toddlers. It is a great way to deliver calcium and high quality protein, etc. But if a yogurt has a specific bifidobacterium that has this benefit, yes, then you have to make sure baby's getting at least 10 to the 8th colony forming units of bacteria, then you can call that food containing a probiotic. If that yogurt has any lactobacillus, any bifidobacteria, no data, then we can't.
Another question is, what is the best probiotic formulation you would recommend?
Yeah, again, this goes back to what are you using it for, right? So if we're talking infants today, I would provide an infant, and we're using it for the purpose of maintaining health and supporting a healthy immune response. I do think for all kinds of reasons, using bifidobacteria, that genus, and there's several species in that genus that we can use, and we gave the example of B. lactis, which has the best safety record, is what makes most sense. I would reserve lactobacilli in general for babies where we're giving it for an additional reason, and we talked about functional disorders. I would not, and this, we did not talk about this, but Saccharomyces is a yeast that is also used as a probiotic. And I would definitely not use a yeast in an infant, certainly not in the first year of life. Yeast, unfortunately, even though it has a reasonable safety record in adults, if you have yeast in the blood, you have a problem. And there are very rare, but documented episodes of fungemia. So I would not use Saccharomyces in an infant. I would use lactobacilli in some circumstances, but I would start with bifidobacteria in an infant. For the toddler, it is a little bit more open because safety is less of a concern. And there's a number of lactobacilli, and we mentioned outside L. reuteri, LGG, etc., that can be used in older children. And again, assuming there's data. We didn't discuss data for older children and adults, but you have a bigger latitude.
Doctor, I can say the question of the moment, is there a relationship between COVID and dysbiosis?
Yeah, I wish I could answer that question. Of course, I think we all know we don't have any data whatsoever. Now, COVID. Now, again, in theory, in theory, anything that improves mucosal function, and this is not just probiotics, but anything that improves mucosal function, that improves mucosal secretion of antibodies, etc., would reasonably be something you want to pay more attention to, especially when you're having something like this pandemic. But we absolutely do not have any data to say that there's a benefit or an effect, especially in infants. And remember, again, infants, fortunately, seem to be less prone to developing severe disease, of course, than adults with this particular virus. But again, I think there's other good reasons to use probiotics rather than COVID today.
Doctor, my last question, and it's not related to probiotics, which is quite interesting one, says, if an infant or toddler develop eye conditions, are antibiotics a safe treatment?
If they develop what?
Eyes conditions.
Yeah.
Are antibiotics a safe treatment?
Sure. I mean, again, if they have bacterial conjunctivitis, the answer is yes, but you have to diagnose it. So if a child has bacterial conjunctivitis, of course, antibiotics help. But and very importantly, most of ophthalmic bacterial infections, especially in children, are local infections. So you always use a topical antibiotic rather than a systemic antibiotic or an oral antibiotic. Right. Okay. Again, the link to probiotics and antibiotics has to do with minimizing the damage that using antibiotics has on the microbiota of a child. Dysbiosis happens pretty much in every child that gets antibiotics by mouth. And the good thing is that the ecosystem that a child has tends to be very stable. So once you stop the antibiotics, most hosts, most infants will tend to go back to the ecosystem they have. Some do not. And this is part of the rationale for giving probiotics to infants who receive antibiotics. One, to decrease the disruption of bacteria, to help minimize that major crisis in the gut that has happened with the use of the antibiotic as a side effect. Two, because there's some data, especially for older children, there's some data on probiotics decreasing antibiotic-associated diarrhea, which is very common in babies getting antibiotic. And three, to hopefully, once the child finishes the antibiotic, to go back to what their baseline ecosystem was, another reason for providing probiotics during the episode.
Well, doctors, thank you for your presentation. I also want to thank all the participants for sharing with us this afternoon. And I really wish you a very good night. And I hope to see you soon in our next webinar, which is a webinar related to do's and don'ts in infant nutrition. So I want to see you soon. Thank you all. Be safe.
Well, thank you very much.